Welcome to Midlife Matters. I'm Marie, and each week I'm joined by my friends Julie and Mindy to talk about all the topics keeping women in the middle years up at night. October is Breast Cancer Awareness Month, and Dr. John King is joining us to talk about mammograms. He'll explain why we need them, the difference between 2D and 3D screening, and why they need to squeeze us so hard. He'll also address some of the common myths around mammograms and what we should be watching for in terms of breast health. Let's get started. Hey, Mindy.
Hey, Marie.
Hi, Julie.
Hey, Marie.
It's great to see you guys, and it's our favorite month, at least it's mine. One of my favorites anyways, October, and that means that it's not only time for all things fall, like we talked about in our fall favorites a few weeks ago, but it's also the time that we start seeing a lot of pink in honor of breast cancer awareness.
Pink is the new orange.
We saw lots of pink socks at the football game last night, so this is perfect.
I know. Well, last month we did an episode on menopause, hysterectomies, and hormone therapies. And if you haven't heard that, go back and listen to episode 46. But this month we're going to look at breast health and mammograms. And I guess health changes must be one of those things that really interest women in the middle years.
Unfortunately, yes.
I know there's always something new that we need to be aware of. But lucky for us, Julie happens to be married to the perfect guest for this discussion. Julie's husband, John, is a diagnostic radiologist specializing in breast imaging. John, welcome to Midlife Matters.
Thanks, Marie. Glad to be here.
Yes, we're so happy to have you. And we have got a whole list of myths that surround mammograms. And I am sure that you've heard them all, but we need to hear your expert opinion on whether or not they're true.
Well, let's debunk some myths.
Well, let's start with the first one, that mammograms are only for, in quotes, old people, 40 and older. Why would you need to have a mammogram before then? And is that even true?
So mammograms are for women 40 and older. There are some controversies regarding when women should start getting routine mammograms, how often they should get them, and when they should stop. But in our practice, the American College of Radiology recommends yearly mammograms beginning at age 40. That frequency of mammograms is every year. And that's for average risk women. Average risk about 1 in 8 lifetime of getting breast cancer in this country. So for women that are higher risk, not everyone who's at higher risk, but for some women who are at higher risk, we may start mammograms routinely at an earlier age. And that includes people that have a strong family history of breast cancer. And that means a first-degree relative typically is the highest risk. Your mother, sister, daughter had breast cancer. If you have a male first-degree relative that had breast cancer, that's not very common, but it does happen. That puts you at higher risk. Certain syndromes, there are some genetic conditions that will increase your risk of breast cancer. And then if you had radiation to the chest, typically as a young person or young adult, to treat Hodgkin's disease is the typical scenario these days. You had radiation treatment to your chest, you're at high risk of developing breast cancer and would need to start screening earlier than 40. The particulars of all that for an individual, when they should start and how often below the age of 40 would necessitate a discussion of your individual circumstance with your doctor.
Right.
Now, I guess if you find something or if you're having a symptom before age 40, you would also get a mammogram at that point, correct?
Right. So a screening mammogram is somebody who doesn't have concerning symptoms. So a concerning symptom in the breast would be a lump in the breast or a lump under the arm, nipple discharge, focal pain, and then a change in the skin, either a dimpling of the skin in one area or a thickening of the skin, in particular if it's thickening everywhere. Those situations would prompt a diagnostic mammogram.
So, John, it's already hard to have upkeep to deal with as a midlife woman. So there's the dentist, there's the doctor's appointments. It's just really hard to take care of ourselves. So if I don't have any family history of breast cancer, if I feel perfectly normal, healthy, do I really need to get an annual mammogram?
It is important to get your mammogram. It's once a year. They're typically easy to get. In many situations, you don't need to even have a doctor's order for it. It's typically very quick. in some places, you don't even need an appointment. They will accept walk-ins, and you can get it done quickly without having to necessarily plan too far ahead of time. And there's actually a study that was published by the National Institutes of Health recently that showed that women who get annual mammograms beginning at 40, their risk of dying from breast cancer is reduced almost twice that of women who get mammograms less frequently beginning at a later age. In other words, if you get mammograms at age 40 every year, your risk of dying from breast cancer is almost 40% less than people who don't get mammograms at all. And if you get your mammograms beginning at a later age, say beginning at 50 and getting them every other year, that benefit drops down to about 23%. So there's a substantial improvement in your risk of not getting breast cancer, but your risk of dying from breast cancer. There's a substantial improvement in getting them at age 40 yearly, and that's why we recommend it.
There's some other myths that I have heard recently, either on TV talk shows or on Facebook articles. Myth number 1, wearing an underwire bra can cause breast cancer.
That is a myth. I'm not aware of any scientific study that demonstrates that an underwire bra can cause breast cancer. It can cause some irritation along the underside of the breast. It can cause a ridge that can sometimes be very tender, but I'm not aware that that's an increased risk of breast cancer at all.
Right. So the irritation doesn't cause cancer.
Correct.
All right. What about wearing antiperspirant or deodorant? Can that cause cancer?
I certainly hope not. I'm not aware. Again, I'm not aware of any study that shows that. You would have to do a study that demonstrated that for people who use deodorant regularly, they are at higher risk for developing a certain kind of cancer than people who don't use deodorant.
Nobody wants to participate in that study.
Please wear deodorant.
I hope that at least in the South, there are not enough people who don't use deodorant that could participate in such a study. No, I don't think that's true at all.
I will say, though, that I switched to a natural deodorant. Now, any of my friends that are my best friends should be kind enough to tell me if it's not working. But I did switch to a natural deodorant earlier this year because of those Facebook articles that you see. And I just thought, well, I felt like I was just putting cancer under my arm every morning when using the regular deodorant. Now, I don't know, but it definitely, I think people are under that impression.
Well, I decided that I was going to use the clinical strength because if I'm dying, I better smell good.
Me too.
So I think that word natural can be overused. And sometimes when a word like that gets overused, it's hard to know what somebody means when they use that word. And so, it's not natural at all to put something under your arm to prevent odor. What's natural is that you just have the odor. I mean, that's the way we were made. I suspect that in some cases, anyway, the list of active ingredients in a product that calls itself natural may not be too much different than
that's true.
Yeah.
That's true.
Good to know. Okay.
Any other myths that you have there, Julie?
Yeah, this one really never entered my mind to do, but wearing your cell phone in your bra will cause cancer. True or false?
I've never heard of that.
You don't think that is anything to worry about? If we want to go running or work out with our cell phone in our bra, we're okay?
I'm not aware of any study that credibly shows that keeping your cell phone inside your bra is an increased risk for breast cancer. No.
Well, here's another worry I think that people have. I know that I've had it. I had to go for a mammogram at age 38, and I talked to a friend of mine, and I was so afraid by the time I got off the phone that I was going to actually give myself cancer by going for the mammogram. So do mammograms expose you to an unsafe level of radiation?
No, they don't. So there is an exposure to radiation, and there are people who would say that any level of radiation exposure is unsafe, but we're exposed to radiation all the time. At sea level, living for a year in our latitudes, you're exposed to about the radiation that you would get from having 8 bilateral mammograms. If you live in a high altitude city, then you're even more exposed to radiation because the atmosphere above you is thinner. If you routinely work on an airliner, for example, you're exposed to higher radiation. And so So we're all exposed to radiation, and a routine bilateral mammogram is about the same as 3 chest X-rays, radiation dose. It's significantly less than a CT scan of your chest, and significantly less than the risk. Say if you have a cardiac problem and you go in for a cardiac nuclear medicine scan, that radiation dose is substantially higher than a mammogram. So a mammogram, as far as any of the X-ray tests that we do medically, a mammogram is on the very low end of the radiation dose, and it's considered very safe.
Okay.
There is a risk, obviously, that we may induce a breast cancer by doing from the radiation from a mammogram because the radiation dose is very low, and breast cancers are very common. It's very, very difficult to prove what that risk is, but the scientific community feels like that risk is substantially less than your risk of dying from breast cancer having not gotten mammogram.
Right.
John, from an early age, I feel like I started hearing about self-exams even in grade school. And so I always thought, well, I would know if I had breast cancer because I surely would feel a lump. Is that true?
So there are some breast cancers that women will pick up on a self-exam that may not be visible on a mammogram yet, but in general, we pick up breast cancers earlier than you can feel them. And there are some cancers that don't present as what you would think of as a traditional lump or a mass. And those cancers, we tend to be able to pick up those earlier on a mammogram than you can by self-exam too. So self-exam is important. No test is 100% accurate. A self-exam is easy, it's very inexpensive, and it's universally available. All you have to do is know how to do it and know how to do it the same way every month. And you get a sense for what your breasts are normally supposed to feel like. And then you're looking for anything that feels different than it has before. That's an easy test to do. And the benefit that you might pick up a cancer from doing that is worthwhile, but it's not a substitute for getting your routine mammograms. It's sort of an in addition to, not an instead of, if you will.
Okay, another myth, annual mammograms guarantee breast cancer will be found early.
So there are no guarantees. We like to think there are guarantees. We like to think that when we're going to get in our car and drive to work in the morning, we're going to make it safely. And that's generally true. And that's the way we think about risk, so we can not have to think about risk. There's no guarantee. There's no test anywhere that will tell you that you don't have cancer in any body part, including the breast. A high-quality mammogram read by experienced people will miss about 8 to 10% of breast cancers. There are some cancers that just don't lend themselves to be seen. They're in an area that we can't see very well. They may be hidden by an implant. They may be hidden by dense tissue around them. They don't look different enough than the tissue around them to stand out.
Well, I mentioned earlier, it's already hard to go to the doctor. And once you hit 40, adding the mammogram to that. So say at 40, I go have my first initial mammogram if I'm of average risk and it's normal. Why would I then continue to go every single year? Is that just redundant? And then also, again, you're exposing yourself to radiation, which we talked about. Is it really necessary?
So if you get a normal mammogram at 40, and that means that your mammogram shows no evidence that you have breast cancer at that point in time. That has no bearing at all on whether or not you may have a breast cancer show up on any future mammograms. And so because what we're trying to do, ultimately, our goal is to reduce your chance of dying from breast cancer. If you get a mammogram at age 40, and that's the only mammogram you get, and that mammogram is normal, then you've reduced your risk of dying from breast cancer in that one short time interval. But you haven't done anything to impact your risk in the future. Because your risk continues as you get older, and in fact, from age 40, your risk goes up and then begins to drop off as you get older. Getting a mammogram every year is very important because you want to reduce your risk of dying from breast cancer throughout your whole life, not just at one point in time.
Okay.
If that makes sense.
Yes.
Heard a lot recently about 3D mammograms. How are they different than traditional, and are they really beneficial? Is it more beneficial to have that type done?
So a traditional what we would call a 2D mammogram or digital mammogram is a great test. It's still the standard of care. It's what a lot of facilities still use, although facilities are moving quickly toward the 3D mammography. So a 3D mammogram, we compress the breast, create an image, a flat image that superimposes all the breast tissue onto one image. And so you get, sometimes that overlapping tissue can hide a breast cancer. Sometimes that overlapping tissue can make an area look abnormal when it's just overlapping tissue, not anything truly abnormal. And so the 3D mammography was developed to try to offset some of those things. And so with a 3D mammogram, it looks very similar to a traditional mammogram machine, except when they are exposing the image, the X-ray tube will move through an arc. And so you'll see the X-ray tube actually move as it's taking the image. And it takes that information. The computer will generate a set of images that are little thin, typically 1 millimeter thin slices of breast tissue. So it's like a CT scan, if you will. Instead of looking at a loaf of bread, you are actually looking at a slice of the loaf of bread, and so you get more detail than you can with a normal X-ray. You don't see all the tissue overlapping like you do in a traditional X-ray. So with a mammogram, we actually look at those thin slices on the computer screen. If you have a breast cancer that would ordinarily be hidden inside the denser tissue, it will tend to stand out more because you've minimized the effect of the tissue in front of and behind that small cancer. Likewise, it will cause that overlapping tissue to no longer overlap, if you will. And so what might have been an area that looked abnormal because the tissue was overlapping in a way that was peculiar, that effect is minimized. And so oftentimes you can tell that something is just normal overlapping tissue as opposed to something that might really be abnormal.
Now, is there still compression with a 3D?
Absolutely. Compression is very, very important. Compression spreads the tissue out, makes the tissue more uniform, gives us a much more high detailed image than we could see without compression. And compression, because it does all those other things I just described, it also reduces the amount of radiation we need. The tighter that we can compress the breast, within reason, of course, we don't want it to be unduly uncomfortable, but the tighter we can compress the breast, the less radiation we need to get a high quality image. And so that's all beneficial. Without compression, we wouldn't be able to see anything near the detail that we can see now, and we would not be able to pick up cancers anywhere near the small size that we can see them currently.
Well, knowing that makes that compression more bearable. Thank you for explaining that.
Yes, exactly.
You want to say stop, but if it's exposing me to less radiation and making it better on you to see it, then I'm willing to do it.
Right. Well, John, when I went to a mammogram a couple of years ago, they said, oh, you have fibrocystic breast tissue, which is like real dense. And we recommend that you get the 3D mammogram next year. And so then I have gotten it every year since. So who's deciding who gets the 3D mammograms? Do they offer it to the patient? Does the doctor tell you need it?
So first of all, not every facility has the 3D mammograms yet. I think, as I said earlier, they're moving towards that fairly quickly. And the standard 2D digital mammogram is still the standard of care. It's still an excellent test. There is research that shows that the 3D mammogram will pick up a few more cancers than the 2D mammogram will, especially in women with dense breasts, but even in women that don't have dense breasts. So there is a benefit to getting the 3D. The other benefit to the 3D is, as I said earlier, it reduces, it doesn't eliminate completely, but it does reduce your chance of being called back for something that turns out to not really be abnormal, if that makes sense. Right now, facilities are handling it somewhat different from one another. Some facilities that have 3D will use the 3D for everyone, and then they'll let the patient opt out if there's some reason that the patient doesn't want the 3D mammograms. You know, if your primary care doctor requests that you get a 3D mammogram, and you go to a facility that has the 3D technology, they'll do the 3D mammogram based on your doctor's request. Some facilities that have the 3D mammography will offer it to patients and let the patients decide whether they want it or not, but they won't necessarily do it on everyone. So it's different from facility to facility. If you go to a facility that has 3D, it's a good idea to have it.
Am I being exposed to more radiation if I do opt for the 3D one?
The older 3D technology, the first generation technology, if you will, they did a routine mammogram, the standard 2D mammogram, in addition to the 3D. And I think it's important to have both. And so that radiation dose was practically double the standard dose from a mammogram, still below national guidelines for radiation exposure. But the newer 3D technology will actually take the 3D information and recreate what looks like a standard 2D image from it. And that image has been shown to be highly reliable and of excellent quality, comparable to a standard 2D image. And so those mammograms, the radiation dose is negligibly increased from a standard 2D mammogram. The radiation dose is just minimally increased at all, really, in my opinion, not significantly increased.
And your chance of getting called back for more pictures is decreased with the 3D. So that's beneficial.
Yes. In general, that's true. So if you have a small breast cancer that we can see on the 3D that we couldn't see on the 2D, obviously your risk of getting called back is going to be higher because we found something that's really abnormal. But your risk of being called back because of overlapping shadows causing an area to look abnormal when it's really not, that risk is substantially less with the 3D as opposed to the 2D.
Okay.
All right. So it can be scary to get called back after your first mammogram. So does that automatically mean that you have cancer?
No. So benign breast changes, fibrocystic change, calcifications from fibrocystic change, benign lumps, benign fluid-filled cysts in particular, and even benign solid lumps in the breast are very common, much more common than breast cancer. So we will call back roughly 8 to 10% of women from a screening mammogram as having some potential abnormality. Most of those will have something benign. A small percentage of those will have an abnormality that we would need to keep a watch on because it's very likely benign. Doesn't rise to a level of concern that we would recommend a biopsy. A smaller percentage than that will actually have an abnormality that's concerning enough for us to biopsy. When we biopsy something, most of the time that's benign. About 60 to 70% of the time in general, something that rises to a level of concern that we recommend biopsy is actually going to be benign.
So we shouldn't get too scared when we're called back.
It's very difficult to not be scared in a situation like that. Even when somebody gets called back, sometimes people get very nervous about that, and understandably so, because the significance of what we may be dealing with for the majority of people, even the majority of people that are high risk, something that would get them called back for an abnormal screening mammogram, the risk of that being a cancer is very low. Certainly, we don't ignore those things, obviously, and we wouldn't recommend that a woman ignore a callback for a screening mammogram under any circumstances. But the risk of somebody getting called back and actually having a cancer is still very low.
Say you're called back and then you determine there's nothing suspicious. Are you followed differently after that point?
So that depends on what you have. If we find nothing at all, when we call you back and do additional mammogram pictures and sometimes an ultrasound of an area that we may have been concerned about on your routine screening mammogram, we call you back and we find nothing at all. Depending on the density of the tissue and the nature of what we thought the abnormality might be, then most of the time we will let you go back to routine yearly screening. Occasionally we'll recommend that someone in that situation come back in 6 months and let us look at that breast with a mammogram one more time, just to be doubly sure, if you will. Some people, if you have an abnormality that is very likely benign, but we can't just say it at one point in time, then we will follow those up. Or at least we will recommend they be followed up. Typically, that's at 6 months, 12 months, and 24 months. Sometimes we'll go out to 36 months follow-up just to make sure that something's going to be stable over time and therefore, allow us to call it benign based on its behavior, even though we couldn't call it benign at that one initial point in time.
That's good to know about the callback, because I think that's one of the reasons sometimes we don't even want to go for our mammogram, because
Right.
it's like, oh, well, I have this trip coming up in a few weeks, and if they call me back, it's going to ruin my trip, or, like we just don't, or they're going to call me back on Friday and they're not going to be able to get me in until the next Thursday. Now I have 6 days of Dr. Google scaring me out of my mind. And
Right.
like, it's just so stressful. I'm sure that you guys in the back, the radiologists, are aware of those feelings.
We are. That's of a definite concern to us, too. And our primary concern is to pick up a breast cancer as early as we can.
Mm-hmm.
Knowing that there are benign things that we see commonly, we don't want to call somebody back unnecessarily, because we know that adds stress. If we can do better than that, we want to.
Mm-hmm.
Right.
We feel like we need to look closely at another area. We will call somebody back, and we apologize for the distress that causes. We're doing it with your best interest in mind. And
Sure.
so we know we're going to cause distress. Actually, there was a U.S. Preventative Health Services task force took into account the stress caused or the distress caused by having an abnormal mammogram as a reason to not get mammograms, which I think is not the best recommendation.
Yeah.
So.
All right. Well, I think everyone is aware of the stress. It's just one of those like necessary evils, probably.
Right.
One thing that I think is important, if you go to a facility and you come in because you think you may have a problem, or your primary care provider may think you have a problem, or if we think you may have a problem because of an abnormal screening mammogram, when you get called back under that circumstance, you should get the report of what the radiologist thinks before you leave that facility. Oftentimes, the radiologist will convey that information through the technologist who actually does the X-ray pictures or the ultrasound. Will just let you know, we see something that's a benign cyst. We think you can go back to your routine yearly, or we feel like something is, very likely benign. We want to keep a close watch on this. And so you should leave with that information in hand. Sometimes if you go to a new facility and you've had mammograms before, but not at our facility, we will request your prior mammograms. And so we may give you just a preliminary report pending looking at those prior mammograms to give you a definitive answer. But if you come in to a breast center with a problem, a suspected problem, then you should leave with an answer about what the next step ought to be, whether that's go back to your normal routine or come back at a short time interval, or we need to do a biopsy. In our practice, if we have a situation where a woman's going to need a biopsy, or we don't see anything, but because of the concerning nature of the problem they came in with, clear or bloody nipple discharge, for example, or an unexplained lump, like somebody comes in with a lump or with skin dimpling or something like that that's concerning, and we don't see anything on a mammogram, we may recommend that person see a surgeon and get a breast surgeon's opinion about what to do next, despite the fact that there's nothing on their mammogram. If we recommend someone see a surgeon, or if we recommend that someone have a biopsy, we, the radiologist, will always go talk to that patient directly. And if a patient specifically wants us to talk to them as opposed to conveying the information through the technologist, then we will go talk to that patient directly and answer their questions as best we can and give them our idea directly about what we think. And so that's really important. Now, that's not going to happen in a screening setting. In a screening setting, you come in, you get your mammogram done, and then we review those at a later time, typically later the same day. We don't give you those results at the time. A lot of facilities will, and we strive to do this if it's very, very difficult for you to get back. If you have mobility issues, if you have transportation issues, or if you live, there are some people that come to get mammograms from our facilities that may live 100 miles away. If we know that situation, we'll strive to go ahead and read those screening mammograms while the patient's still there and give them their results immediately because of the extreme difficulty in them coming back if they needed to.
Mm-hmm.
And then if we find an abnormality in that situation, we'll try to work it up at that point as opposed to having them come back.
Well, that's
I think it's good to know that you have the option of talking to the radiologist at that time, because I don't think that's something that maybe everyone's aware of.
Yeah, I didn't know that
you
either.
could request.
Yeah.
In our facilities where I practice, and I think it's true in a large number of facilities, if you have a problem or a potential problem on your mammogram or on a physical exam, and you come in with that problem, and you ask to speak directly to the radiologist, that radiologist ought to get up and speak to you. I think I think we owe that to our patients, and I feel very strongly about that.
It's so funny because I feel like you're in the room and you have like this technician, and then it's like Oz. Like, they're somewhere behind the curtain back there,
right,
deciding my fate, but I don't know who they are or what they look like. I won't know who they are until I get my letter in the mail saying your mammogram was fine and there's a signature. Like, I don't even know who the person was while I'm there. So, yes, there is that sense from the patient that there's like this separation between you and the radiologist.
Well, and oftentimes you don't pick your radiologist. You pick your facility and whoever the radiologist is there that day. And so we have a burden of making sure that we have highly trained, highly competent people reading your mammograms, because you don't have the opportunity to choose. That you just choose, as I said, you just choose the facility. And then I think this is much less common now, but in recent memory, a lot of people didn't know what a radiologist was. They thought the technologist who was shooting the pictures was the radiologist.
Right.
They didn't know that a radiologist was actually a medical doctor that went to medical school and did extra years of training after that. And that's, like I said, less common now. I think people are more sophisticated in general. They're more willing to inform themselves than they used to be. And so the fact that we're actually medical doctors, I mean, I've had people tell me that literally they say, well, my doctor reads my x-rays. What are you doing, interjecting yourself into the process? And that's an opportunity to educate somebody, but it's really, I think it's genuinely difficult for people to necessarily know who we are or what our role is.
Right.
I think the whole process can sometimes just be very confusing. You know, the patient doesn't really know what to ask. They don't understand all the players involved, you know, with different types of tests that you're asked to do. So this is, I think, very helpful for me and hopefully to our listeners to just realize, you know, the different people involved and even just reading a mammogram.
Well, and it's also really, really common. If you are faced with a bit of bad news or even something that seems like bad news at the time, but ultimately proves itself not to be bad news, it's just not the news you wanted to hear at the time, whatever questions you might have in your mind, they just kind of disappear. I mean, you just don't know because you don't expect that.
Right.
It's really, really, really difficult to know what questions to ask at the time. And so many of us, especially those of us who are more talkative, will try to anticipate those questions and try to at least answer the basic ones. You know, what does this mean for me now? What might this mean long term? The most important question is, what do we do about this next? And that may not be the most important question that the patient has in front of them at that very moment, but ultimately that's from the standpoint of what I'm trying to do. And I think once the patient sort of takes a deep breath and thinks about what's happening a little bit, I think the very, very important question is, what do we do next?
Well, we all jump to, are we going to die?
Yeah,
So
exactly.
like I had a doctor who, he was actually a gynecologist, but he would always be like, okay, you're not going to die from this. And immediately after he says that, I can listen to everything he says next. But I really, really need that answered first. Is this going to kill me? If not, okay, well, now I know that we're going to go through these steps. I think that's really what we're all afraid of when we go for the mammogram. Are we going to find out something that's going to end our life?
And that's one of the things that doctors in general are very, very uncomfortable talking about, or it's death or any kind of a bad outcome. That's just something that we're trained to know that that's a possibility. We're trained to know that that's out there and that certainly can happen.
Right. Obviously, you're in the business of prolonging life, of saving life. So,
right. And that's a negative. And nobody wants to talk about a negative. We want to talk about something positive. And so if somebody can bring that topic up in a way that makes you feel better about it, then that's great. I mean, it's sometimes difficult to read people. And I can envision some people, if their doctor said, now, this is not going to kill you,
I would
That
be
All they
might,
hear
worried
is
about
kill.
that.
that might alarm them as opposed to
I would like-
just because you brought the topic up, that might
It's
alarm them
true.
as opposed
Right.
to be soothing. And so
That's true. I just
that's
think
a-
everything's going to kill me, so it's
Yeah.
reassuring for you to tell me that it's not.
That's
So
Marty's
so
baseline.
you've found a doctor that you can relate
Fits
to at
with
a
you.
very, very high level, and that's
See, I'm not worried about death. I know death is going to happen. It is a certainty. However, I am worried about living sick. I don't want to live sick.
Right.
That would be my main concern.
I want
Right,
to live even if I am sick.
Just kill me.
This next question is kind of two-part, and it deals more with the facility. How important is it to go back to the same place? Because you mentioned, you might not have films from a previous mammogram if you're new to a certain location. And then part two is, do all mammography centers require some kind of certification? Like, is there something to look for, some kind of standard that they've met?
every mammography facility, every facility in the country that offers mammography by federal law has to meet American College of Radiology standards. And those are rigorous standards, and they're ongoing standards. So we're looked at periodically to make sure that we continue to meet those standards. And the FDA, the Food and Drug Administration, through the Mammography Quality Standards Act of 1992, mandates that we also be inspected annually by the FDA. So a federal government official comes in, looks at our records, looks at our images, makes sure that we have people who are not only well-trained, but have documented ongoing competence in maintaining our continuing education and meeting standards of how many mammograms that we read ongoing to make sure that we're well-trained and competent in what we do. So every facility has to meet those. Those are absolute minimum standards. You can't open your door, you can't turn your lights on without meeting those standards. You're free to go to any facility that you want to. If you have a facility that you know and you're comfortable with and you like, if your primary care provider recommends a certain facility based on their knowledge and experience, then that's very important to take that into consideration. Once you go to a facility, as much as possible, you should go to the same facility as long as you're comfortable with the care that you're getting there and you're not displeased by anything that happens. And the reason for that is what we call continuity of care. If you go to different facilities, your new facility is obliged to try to get your prior mammograms from your prior facility or your prior facilities. That can be an easy process. Sometimes it can be a difficult process. That creates sometimes a delay in reading of your mammogram. For example, in our practice, if we have mammograms that we feel like we need from an outside facility, we will hold those screening mammograms for up to 2 weeks before we will attempt to read them, because it's so important to have those prior mammograms. Every woman's mammogram looks a bit different than every other woman's. And so what may be perfectly normal for one woman could be a sign of an early significant problem for another woman. And so having those prior mammograms to compare to make sure that things are stable over time is very, very important. And that's all much easier if you go to the same facility every time.
Okay.
Even if I'm not that great about going to the doctor every year, like say someone doesn't regularly go to the doctor, but they do want to regularly get their mammogram, do they need to go to the doctor, get a referral, or can they just go get their mammogram?
So if you are getting a screening mammogram, in other words, if you don't have a significant breast symptom, a lump in the breast or under the arm, skin changes, skin dimpling, discharge, focal pain in one spot, especially persistent pain. If you don't have any of those symptoms, then you can you qualify for a screening mammogram. You don't have to have an order from your doctor. Most facilities will require that you have a doctor of record or a provider of record that can be responsible for receiving the report and dealing with it, but you don't have to have an order from your doctor to do that. Now, if you need a diagnostic mammogram or a breast ultrasound or something like that, you do have to have an order from your doctor for that.
Okay, that's good to know. For listeners, if you have fallen a little bit behind on your mammograms, or this is something that's coming up and you've been trying to think about what you're going to do, I hope this was helpful for you. I know that in the past, I've thought about pairing my mammogram with October, but I found that it's hard to get in October. So if you call this month and you feel like, oh, the wait time is so long, try calling even in November or a different month. I do think it's probably busier in October. Is that true, John?
It is true, and there's a lot of reasons for that. So October's Breast Cancer Awareness Month. It's sort of at the forefront of people's minds. October tends to be when Susan Komen races are held, and there's a lot of awareness. And so that puts it on people's minds. Toward the end of the year, for people that have high deductible healthcare plans, they've met their deductibles, and so they're trying to get as much done as they can before the beginning of the year. In the beginning of the year, the first half of the year, that's less of an issue. What I'd like for people to take away from this is mammograms are inconvenient. They remind you of something that you probably would rather not be reminded of, and they do save lives.
Right. That is true. And people are going to hear a lot about mammograms this month. And I hope that this is another useful tool to educate people. We appreciate you coming on, John, and sharing your knowledge with us.
Thanks for taking time out to answer our questions, because we don't always get to sit with our doctor for an hour and ask all these questions. So.
That's right.
Thanks for asking. I'm happy to be a part of it.
Yes. It's time to move into our I'm a Fan segment. All right, John, and our guest gets to go first. And so we just can't wait to find out what you are a fan of.
I'm a fan of sailing on Buzzards Bay.
Where is that exactly?
Buzzards Bay is on the southeast coast of Massachusetts. It's a wonderful place. A bit challenging at times, but my wife and I have had a chance to sail there some this summer. I've had a bit more opportunity to do that. Some wonderful people and wonderful sailing, challenging it again at times, but a beautiful, beautiful area of the world.
Oh, that's awesome. Wow. And, I think that John might have a little bit of self-serving motivation in sharing this, because I think, Julie, you were a little afraid on Buzzard Bay, and this is kind of like a little way to get you back out there. Am I right?
Yeah, like it's the one thing he loves to do, and can't do it without you, Julie. And yeah. Aww. When he said challenging, he was right. I got a little scared because It was pretty wavy and I was getting a little sick. But I'm willing to try again.
All right. Well, now we have it on record. She's willing to do it again.
Well, so we have a small boat, and the waves in Buzzards Bay can get a little substantial. And we were in an area that locally I think is called the washing machine. Ooh. Because of how the wind and waves interact against the shore.
They come from all directions.
There were no dry clothes in the cockpit of the boat. We took a couple of waves over the top of the boat and inside, and it was a little unnerving. Common term that you might hear sailors use is uncomfortable but not unsafe.
Right.
And that's what we were.
So I'm saying I'm uncomfortable but not unsafe. I'm uncomfortable but not unsafe. So sailing is like getting a mammogram.
Oh, my goodness.
All right, Julie. Well, what are you a fan of?
Well, I'm a fan of a store, and I hope I'm pronouncing this right. I even looked it up. It's called Uniqlo.
Oh, how do you spell that? No.
Uniqlo. It's a Japanese store. I have actually been in a store in Orlando. They have one in downtown Disney or Disney Springs. It's just a really cool store, but you can shop online, and it's great for outerwear, like those little puffer jackets and vests, and they have a lot of really cool coats, and it's priced, I won't say cheap, but it's priced like maybe H&M or...
Yeah, H&M is pretty reasonable.
I've bought some things and they've held up really well. I have a little puffer jacket that I got from there, and it compacts down into a little bag, so I can pack it on trips. Oh, wow. It's a great layering jacket. It's really thin. So yeah, look it up online.
I just looked it up. And if you sign up for email right now, you get a $10 off coupon.
Yes. They have great jeans, but I like the outerwear.
Okay. I'll put a link to that in our show notes, and maybe we can show a picture of your puffer jacket in Insta stories this week. Yeah. Mindy, what are you a fan of?
I am a huge fan this week of grandparents. My daughter, Abby Ray, just hit a bout of homesickness, and I'm supposed to go visit her in a couple of weeks, but could not go right now. My parents, who live in Missouri, just happened to be visiting my mom's family in Georgia. And I called them and I said, hey, is there any chance you guys are going to go by Chattanooga, Tennessee? And they weren't. However, the next thing I know, my dad's got this cabin in North Carolina to meet Abby at for the weekend.
Oh, sweet.
So Abby not only got to leave campus and go see family, which she never gets to do, but she is getting spoiled and loved on all weekend by my parents. I'm so extremely thankful for them because I couldn't be there. We couldn't meet that need for her, but my parents stepped in and, my dad even said, hey, you can take off work. I'll pay you. How much do you make per hour? And he's given her more, but he's paying her to take off work. And
what a treat.
Yeah.
I just, as a mom, that just means so much to me to know that my parents stepped in. And Abby is so excited to be with her grandparents this weekend, all by herself.
Oh, that's wonderful. Well, I hope they have a great time. I bet they will
Yes.
in the mountains of North Carolina with the leaves changing and everything.
Yes.
That is super.
What about you, Marie?
Yeah.
Well, I'm a fan of something that I'm doing today, home tours. So there's a neighborhood in Nashville that is having home tours, and these are homes where people live, but they're opening up their homes probably for some kind of fundraiser. You buy a ticket for $10 and you get to go in X number of homes. Usually when I've gone on them before, they've been anywhere from 5 to 10 homes. But I just love going into homes that people live in because you get so many ideas for your own home. And Julie, you and I have done this before with Christmas home tours.
Mm-hmm. I love that too.
How
That's
fun.
neat.
Yes.
Yes, so I will have a good time doing that. And I think it's an excellent way to raise funds. I mean, I don't know many women that don't want to go in other people's homes.
It's true.
So, John, once again, thank you so much for coming on. If anyone does live in the Nashville area and they want to go to your facility, what is the name of that?
My group practices at the TriStar facilities. My home base typically is at the Summit Breast Center in Hermitage.
I know that I've gone to your facility, but the one based out of Centennial. So if you're local, there are several big hospitals that you are at.
Mm-hmm.
Yeah.
And I work at Centennial as well.
Okay, excellent. All right. Well, thank you so much for coming on and sharing with us. And I'm sure there may be in the future some medical question that we need to have you come on again for.
Happy to do so. Thanks for inviting me.
All right. It was great
All
to
right.
see you, Mindy and Julie. Hope you guys have a great week.
Thanks
bye.
so much.
Have a great
You
day.
too.
All right. We'll talk to you later.
All right. Bye.
We're so glad you joined us today. If you're a fan of Midlife Matters, please tell a friend and help them hit the free subscribe button on their favorite podcast app. We also hope that you'll follow us on Instagram at Midlife Matters Podcast. This is where you can see the things that we talk about on each episode, and we'd love the chance to get to know you better in the comments. You can also contact us at midlifematterspodcast@gmail.com. Thanks so much for listening, and we'll see you next Wednesday.